Artemis.
Yeah, thank you so much, Rupert. You can hear me okay?
Yep, no, that's coming over nicely.
Thank you so much for inviting me to share most recent work. So again, my name is Artemis Zavaliangos-Petropulu. I'm a postdoc at UCLA at the Brain Mapping Center with Dr. Katherine Narr. I got my PhD in neuroscience from the University of Southern California, specializing in brain imaging. And I know that the audience here has quite a few clinicians, so I'm very eager to discuss these results with you all. So I'll be presenting two papers. Most of the time will be spent on this diffusion paper, and I was given some bonus time at the end to share our most recent neurocognitive findings. So we have nothing to disclose. And for this first paper, titled Changes in White Matter Microstructure Following Serial Ketamine Infusion in Treatment-Resistant Depression, the first author is Taraku, who's a very talented research assistant in our group. I will advertise he's applying for PhD programs to start in fall 2024 in case you're looking for an excellent graduate student. So we're all familiar with how it's been pretty widely replicated that sub-anesthetic ketamine reduces depressive symptoms within hours and in patients who are treatment resistant. But a lot of us are here because the mechanism underlying the therapeutic response is unclear. So studies focusing on targeting the molecular and cellular mechanisms underlying ketamine's antidepressant effects suggest that ketamine leads to neuroplasticity. Now, this neuroplasticity might be triggered by various molecular cascades that we're still trying to understand, whether it's downstream mechanisms of NMDA receptor antagonism, AMPA receptor activation, downstream activation of BDNF, and so forth, all leading to this synaptic and dendritic remodeling that underlies neuroplasticity. So this remodeling is thought to subsequently modulate brain circuitry, which with functional brain imaging studies, we repeatedly see that ketamine alters functional connectivity of brain networks involved in mood and behavior. So for example, in this figure here, this is from our most recent review of brain imaging studies of ketamine treatment. We pulled together findings from resting state functional connectivity studies, and we saw patterns following ketamine treatment of increased frontal limbic and frontal striatal functional connectivity, which are networks that have been shown to be hypoactive in depression, and decreased within limbic and within default mode network, which have been shown to be hyperactive in depression. So we know that these functional brain systems are built on architectures of direct and indirect white matter pathways. And we can study those white matter pathways using diffusion MRI, which is a brain imaging technique that measures the movement of water molecules in the brain across various tissues and can be used to model white matter microstructure. Now, prior treatment studies that report changes in white matter microstructure using diffusion will lead us to believe that these changes suggest the possibility of neuroplasticity. Now, in terms of ketamine studies, there are very few that have actually used diffusion to study ketamine. The majority have focused specifically on pre-treatment diffusion associations with treatment outcomes. And almost all have modeled white matter microstructure using what we call fractional anisotropy, or FA, which is a measure that's derived from the diffusion tensor model of diffusion. Now, this is a commonly used measure thought to be an estimate of the organization of white matter microstructure that I'll get into in a little bit. So only one study so far has actually looked at change in white matter microstructure. This is by Sidner et al. 2020. However, they specifically looked at acute change, so pre-treatment to 4 hours following one single ketamine infusion. And they found some interesting correlations between this acute white matter change and changes in depressive symptoms 24 hours post-treatment. So for our study, we are interested in studying changes in white matter microstructure 24 hours after completing serial ketamine treatment to see if we can identify evidence of neuroplasticity linked to improvements in symptoms. So the data that we use as part of an NIMH-funded U01 here at UCLA titled The Perturbation of Treatment-Resistant Connectome by Fast-Acting Therapies. This is part of the Human Connectome Project. We collected longitudinal brain imaging as well as demographic, clinical, behavioral information, and blood over the course of 3 rapid-acting treatments. So looking at sleep deprivation, ketamine, and electroconvulsive therapy. We also had a small sample of healthy controls that were collected for cross-sectional comparisons. I will note that the data collection is now complete, and we've been working on this data retrospectively. So focusing specifically on the participants who received ketamine treatment, the ketamine treatment in the study was 4 4 infusions of racemic ketamine at 0.5 milligrams per kilogram over 40 minutes, administered over the course of 2 weeks. These participants had moderate to severe depression and were considered treatment resistant. Also, these patients were permitted to remain on antidepressant medication as long as they had been stable for at least 6 weeks. So in patients, we looked at brain imaging and clinical assessments pre-treatment and 24 hours following the 4th infusion. The brain imaging that we collected included a T1 and T2 structural MRI, as well as a high-resolution multi-shell diffusion MRI. The clinical assessments included the Hamilton Depression Rating Scale to assess mood and the Snaith-Hamilton Pleasure Scale to assess anhedonia. The healthy controls did not receive ketamine treatment, but we did have brain imaging for 49 healthy controls, and longitudinal brain imaging collected 2 weeks later, so in the same interval as the patients in a small subset of the data, so 16 subjects. So this is the table with the demographics from the paper. Thing to note is the healthy controls were significantly younger than the patients. So the main goal of including the healthy controls was more to help try and interpret these longitudinal changes that we saw in our patient data. Nope. Okay. So in this bar graph, we see a nice replication of prior ketamine studies because we see a significant improvement in mood as measured by the Hamilton on the left, where lower values mean less depressive symptoms. And on the right, we see improvements in anhedonia measured by SHAPS with higher values indicating less anhedonia following treatment. So for the brain imaging, we use the human connectome minimal preprocessing pipeline. Now I'm about to get into the models that we use, which involves a lot of fancy math, but it's not necessary to understand the nitty-gritty details. I'm just going to give you a broad overview. So like I mentioned previously, a majority of prior diffusion ketamine studies have modeled white matter architecture using the diffusion tensor model, or DTI. This is one of the oldest and most widely used models of diffusion, but as brain imaging technology has advanced with higher spatial and temporal resolution, there have been newer models developed to accommodate this higher resolution data. So for example, the NODI model, which stands for Neurite Orientation, Dispersion, and Density Imaging, is a higher order diffusion model that's thought to be better suited for the analysis of multi-shell diffusion data, which is what we have in our study. So now the DTI and the MODI models are both sensitive to detecting changes in white matter microstructure, and they've actually been shown to be correlated both in general and within our own data. But it's thought that the NODI model provides greater biophysical specificity with respect to isolating change in neurite or axonal arrangement, dispersion, and so forth. And it takes into account the fact that you can have multiple types of multiple tissue compartments within a single voxel in the brain. So while FA from the DTI model estimates general organization of white matter microstructure, from the NODI model, we can calculate this measure called the Neurite Density Index, or NDI, which is thought to estimate the density of axons in white matter, and the Orientation Dispersion Index, which is thought to describe the degree of the dispersion of the fiber bundles in the white matter, so how parallel or how crossing they are within a voxel. So FA, NDI, and ODI are the 3 measurements that we looked at across white matter in our study. So to optimally align white matter within subjects across time and across all subjects, we use longitudinal tract-based spatial statistics. The general purpose of doing this is so that you can look at changes at the voxel level in all of the major white matter tracts. So essentially what we end up doing is aligning each person's FA, NDI, and ODI images to a common white matter skeleton, which is what you see highlighted in green in this brain here. And analyzing each of these measures along these white matter areas. So to get into the results, to look at longitudinal change in white matter microstructure, we use this tool called FSL Randomize, which is a widely used statistical tool in brain imaging that allows us to compare pre and post-treatment white matter along every voxel. We adjusted for age and sex and corrected for multiple comparisons at the cluster level. We found some really interesting significant changes, specifically decreases in neurite density, so the density of axons in the white matter within occipital temporal tracts of the left hemisphere. So we have plotted in red the areas that were significant on those brains. So they include the posterior thalamic radiation, the inferior longitudinal fasciculus, the forceps major, and the retrolenticular part of the internal capsule. So in the box plot, what we did is we took all of the regions that significantly changed and averaged them, and we show them pre and post treatment. And so we've highlighted in blue for the participants who showed decrease in this area. And so it's pretty interesting because it is a pretty overwhelming majority. Now, we didn't find any significant changes in ODI or FA, and we also didn't find any significant changes longitudinally in the healthy controls. So to get into these findings a little bit, we're very excited because these are the first to our knowledge to report change in white matter 24 hours following ketamine treatment. Interestingly, our group has previously published on brain activation in an overlapping sample using fMRI, and we found changes in bold signal in regions receiving connections from the white matter tracts that were implicated in our findings, specifically in the left visual cortex and temporal regions. So taking these functional and structural changes into account, we believe this may suggest the possibility of structural neuroplasticity. So change in NDI might reflect neural reorganization that leads to changes in connectivity or functional systems. It is interesting, though, because we see decreased NDI is often associated with signs of neurodegeneration, whether it's with Alzheimer's disease progression or traumatic brain injury. However, it's important to note that NODI is still just a model of water diffusion, and we can't actually infer precise biological meaning underlying the change in neurite density, specifically in the study. But what we can do is look at correlations with change in white matter microstructure with change in symptoms, which is what we did next. So continuing with that same statistical tool, FSL randomized, we looked at correlations between percent change in FA, NDI, and ODI with percent change in depressive symptoms and change in anhedonia. And we found significant correlations between decreases in NDI and improvements in anhedonia, specifically within voxels of the left internal capsule, which connects the cortex to subcortical regions like the striatum and the thalamus, as well as the superior longitudinal fasciculus, which is a major white matter tract connecting frontal, temporal, parietal, and occipital cortices. We did not find any correlations between ODI or FA with any of these clinical assessments. So anhedonia is a core symptom of depression thought to reflect disturbances in reward processing involving prefrontal, striatal, and limbic structures, and ketamine has shown to be particularly effective in treating anhedonia. Now, the internal capsule white matter changes were especially interesting because the internal capsule connects frontal brain regions with subcortical areas like the striatum, and changes in frontal striatal functional connectivity have been shown to be correlated with improvements in anhedonia following ketamine treatment. So this finding supports the hypothesis that ketamine may modulate limbic and reward circuitry and suggests that the microstructure of white matter pathways within these networks contribute to ketamine's anti-anhedonic properties. We've also identified correlations between anhedonia and the superior longitudinal fasciculus. So the superior longitudinal fasciculus, like I mentioned before, is a large white matter tract connecting frontal, temporal, parietal, and occipital cortices. It's involved in a number of different behaviors and aspects of emotion, but in the diffusion depression literature, we see it's been repeatedly implicated. Interestingly, there's been a study that shows increases in FA correlate with greater anhedonia symptoms in patients with depression. So again, these findings suggest that changes in microstructural features in the superior longitudinal fasciculus may also contribute to ketamine's anti-anhedonic properties. So we also did a small cross-sectional comparison of pretreatment patients versus healthy controls, and we did not see any significant differences in neurite density between patients and controls in patients pretreatment. However, we did see that the patients showed higher ODI and lower FA in widespread overlapping white matter tracts. Now, prior studies have found differences in ODI and NDI in patients compared to healthy controls, but it's important to note that this study was not necessarily powered to do cross-sectional analyses, and structural differences between patients and controls are known to be very subtle and require large samples to identify. So the takeaway of the study is that we observed significant changes in white matter microstructure 24 hours following serial ketamine treatment. We saw changes in the superior longitudinal fasciculus and the internal capsule were correlated with improvements in anhedonia. Now, in terms of future directions and things that need to be addressed, we don't know how transient these changes are. So we are interested in looking at follow-up. So we do have 5 weeks post-treatment data collection that we can look into. We're interested in seeing if these changes are still sustained at that point. Furthermore, we need to do some replications of our findings. Again, to our knowledge, this is the first study to show longitudinal changes in white matter microstructure and to use this NODI and NDI measure. So it'd be great to have other studies to compare our findings to. Like I mentioned previously, we can't infer the precise biological meaning underlying changes in neurite density in this study. So follow-up studies are necessary to get to the biological relevance of the changes that we observed. Additionally, our patients were permitted to remain on stable antidepressant medication. It's very possible that there may have been some kind of medication interaction influencing the changes that we observed. Unfortunately, given our sample, it's very difficult to control for these medications because we don't have a great distribution, but this is something that future studies could investigate. And finally, the study was a naturalistic design. So while we did not see longitudinal changes in the healthy controls, it would be great to look into this again with a double-blind placebo design. But overall, we're very excited about these findings because it's led to a number of new ideas, things to investigate to really get to the root of what's driving ketamine's therapeutic mechanism. Before we move on to the next paper, here is a picture of my dog Moose as a quick palate cleanser and intermission. And now more ketamine. So over the next few minutes, I'll spend some time discussing our most recent paper, looking at changes in
I'll tell you what, Artemis, I wonder whether we should
do a break.
Just take some questions on that first study first.
Sure.
Is that all right? And then
we'll of course.
We'll do it like that. So if you'd like to put questions in the chat, that would be great. Or if you want to put your hand up or whatever, all that's good. So yes, I have a question. I mean, you said that in a sort of slightly provocative way that reduced NDI was associated with neurodegeneration. Which left me wondering whether you can say anything about absolute levels of NDI and how these compared between the patients and the controls.
Yeah, so you mean for like overall white matter?
Yeah, yes, but particularly in these tracts. So were they, for example, higher to start with than in the controls?
Yeah, so that again, we didn't find significant differences between patients and controls. So whether in NDI specifically, which suggests that our results are that these changes are very subtle, because we didn't see changes because we couldn't compare with the healthy controls NDI, whether that's because of a small sample or the age difference. It's hard to say. And again, we don't have anyone really to compare it to. In the one study that reports differences in NDI, they found patients showed lower NDI compared to healthy controls. So this could mean a number of different things. But again, NDI specifically, we want to assume that it represents how tightly packed the axons are, but we can't really say that that's exactly what's happening. There could be a number of different things involved. It could be changes in connectivity, reorganization of the brain. So it's not necessarily, we don't have any actual biological information, right? It's just an estimate of diffusion. In the brain.
I mean, this shows my ignorance, but how would you expect this to correlate with the sort of synaptic density at the ends of these tracts?
Yeah, so again, when we say neurite density, we're talking about not necessarily axons, but the like dendrites and the synapses. Yeah, so I guess I could have explained that a bit better. and sometimes, depending on the resolution, depending on the voxel, it could include axons, but it's an estimate of what's going on within a single cube of the brain. So it's hard to tell with this brain imaging data specifically, but right, given that we're seeing changes in the preclinical models with right, the synaptogenesis that we're observing, that is that we think might be the reason why we're seeing improvements in clinical assessments, it might reflect some kind of reorganization there.
Is there any data from the preclinical models with NODI in these depression, like or treated with ketamine? I mean, because I'm also left the same way, wondering that on one hand, you presented that the decrease in NDI is neurodegeneration, but on the other hand, with treatment, you're actually seeing a decrease in NDI. That's one question. The other is, I noticed that your measures in the paper, your measures, you're normalizing by like total, I think, white matter volume fraction or something like that. Is that contributing to like potentially a pseudo atrophy kind of like an inference that it's actually in the reverse direction, but just because it's a artifact of the normalization procedure? It's not there in your slides, but it's in the paper.
Oh, in the paper.
Yeah.
So I don't think we normalize for total white matter volume.
Fraction of the total white matter volume. That's what I read from your paper.
Oh, so I think that describes the model for the neurite density.
Oh, all right.
Okay, yeah. So I've been looking for NODI animal model brain imaging studies. I haven't come across any yet, but if you come across them, please let me know. It'd be great to look into that and do some comparisons. But yeah, again, it's complicated. So because we see trends in NDI with Alzheimer's and with traumatic brain injury, we assume that means neurodegeneration, but it doesn't necessarily imply neurodegeneration. I think that's
you said that you don't see any significant differences in NDI cross-sectionally. Are there trends?
I don't believe there were trends, at least with the multiple comparisons corrections that we had. I'd have to go back and look specifically, but I don't believe that we saw.
In the UK Biobank, for example, when you compare healthy controls versus MDD, there is reduction in neurite density.
Yeah.
In the MDD, sorry.
Yeah, but again, UK Biobank is massive, and so we were.
Of course.
Yeah.
Yeah.
So, and again, even there, we're trying to understand what does that mean in terms of what is the difference between someone with depression versus a healthy control. When you're looking at diffusion, does it mean that there is atrophy in their brain, or does that mean that their brain was initially organized in a different way? And with whatever medication, it changes its organization with treatment.
All right, thank you.
Just to follow on Rito's comment. So the sentence in the method says that ODI and NDI are multiplied by the white matter volume fraction estimated using the multi-tissue response to obtain the white matter signal contribution for each NODI parameter. And so wouldn't that imply that, I guess I'm wondering if you did get an increase in white matter in other regions, might you be seeing just a relative reduction in regions that aren't changing? Could that be one interpretation of the data?
Yeah, I guess that could be one way to interpret it. I would have to go back and we can try that out with our data and see if that's what's driving these decreases. Definitely.
Yeah, maybe you could try it without that normalization factor.
Yeah. I'll definitely make a note of that. And we can
try to get more at an absolute measure.
We've got a couple of questions in the chat. Was there any difference between males and females?
So we didn't explicitly look for the effect of sex in terms of white matter. We just covaried for it. There weren't, I don't believe that we saw any differences in terms of treatment response, but that is one of the next follow-up analyses to do, is look at sex effects.
And I'm going to invite Tiago to ask his question. I'm not sure if it comes over well in the chat, so.
I'm here. Hi.
Thanks, yep.
If I got it right, ketamine reduces neural density in the white matter, right?
Mm-hmm.
And you know if oral meds or just any improvement, like, I don't know, any other antidepressant medications do the same, or is something specifically found on ketamine treatment?
Yeah, so I know there are papers that have looked at changes in white matter with other antidepressant medications. Right off the top of my head, I can't remember. I don't believe I saw any with NDI, but I have to look again. But I know there are some changes in white matter microstructure following treatment. But again,
Okay.
this is, oh yeah, sorry.
So it's a feature of the treatment, not a feature of specifically ketamine.
Yeah, so you would expect, right? Like, so we've published with sleep deprivation, for example, we see changes in white matter microstructure that are also correlated with behavioral changes.
Great, thank you.
You rather tantalizingly pointed to some longer term data. Do you know when those are going to be available?
So we've already collected them. We're just working on analyzing them right now. The problem is it's a smaller subset of the sample that has this follow-up data, so we're not quite as highly powered, but that is something that we're looking to next.
Okay. Should we, unless there are other questions, in which case people should.
I just have a quick question, maybe before Artemis moved to her next.
There? Yeah, go on.
That's what you were alluding to. Artemis, would there be like any effects of, I think you mentioned, like, you know, people may have been on other medication and these may like have interfered, right, with the data. What about in terms of duration of illness? You know, people who has, you know, with long history of depression compared to, you know, others.
Yeah, so we do have that information. So we have duration of illness as available for our data, and we tested it as a covariate. It didn't significantly impact the results. Now that could be because our sample is particularly severe, given that they're all treatment resistant and have tried at least 2 antidepressant medications. So because we have a more severe sample, we could just be seeing a more severe population, but definitely with like the larger, I know, Enigma studies where they've looked at comparisons between patients with depression and controls in terms of diffusion, you see effects of duration of illness really impacting structurally.
Okay, thank you.
Okay. Any other questions on this before we move on? Okay, so back to your dog.
Back to my dog. Oh, come on. So she's not giving the talk, but it's just intermission. So our next paper was looking at changes in neurocognitive performance in the same sample of patients. So as promising as the antidepressant outcomes have been from ketamine trials, one major concern stemming from the ketamine abuse literature is that high doses of ketamine lead to cognitive impairment. Although antidepressant treatment is administered at a much lower concentration, the dissociative and psychomimetic symptoms still occur during and shortly after the treatment. And there have been some reports of acute cognitive deficits immediately following the treatment. So in order to weigh the clinical benefits and adverse potential cognitive effects, there have been a number of studies that have looked into changes in neurocognitive performance. And interestingly, despite differences in study design, the results suggest that subanesthetic ketamine positively affects aspects of neurocognitive function in treatment-resistant depression in the days to weeks following the treatment, with some studies specifically reporting improvements in visual memory and processing speed. Additionally, there's been some evidence that pretreatment neurocognitive performance may be associated with ketamine-related improvements in mood. So cognitive difficulties are a core symptom of depression and substantially impact quality of life. They're a very tricky symptom to treat and often persist despite treatment-related improvements in mood. So this suggests that cognitive impairment may actually represent a feature of depression that's dissociable from mood. So one of the questions that we've been asking since we see these changes in neurocognitive performance with ketamine is, are these neurocognitive improvements a result of ketamine-related improvements in mood? Are they distinct domains? So a handful of previous papers have used a similar mediation model to ask this question and have kind of come up divided, with some finding improvements in neurocognitive function are independent from improvements in mood, while others reporting improvements in mood are in fact mediated by change in depressive symptoms. So the overall goals of this study was to investigate change in neurocognitive performance throughout ketamine treatment and investigate the relationship between depressive symptoms and neurocognitive function. So again, we use the same data that I had mentioned previously, and we have these additional time points for a subset of our data. So for a smaller sample, we have data collection 24 hours after one single ketamine infusion and at a 5-week follow-up. For clinical assessments, again, we use the Hamilton Depression Rating Scale, but we also use the NIH Toolbox Neurocognitive Battery to assess neurocognitive performance. So this is a psychometrically validated neurocognitive battery that can be used for longitudinal analyses. It looks at crystallized and fluid neurocognitive performance. Under the crystallized element, it assesses language using a picture vocabulary and oral reading tasks. For fluid neurocognitive performance, it assesses complex attention and inhibition using the flanker inhibition task, working memory with a list sorting task, executive function with a card sorting task, processing speed with a processing speed task, and episodic memory with a picture sequence task. And so you can look at each of these tasks individually, or you can average them and look at summarized fluid and crystallized neurocognitive performance. So to look at change over time, we used a mixed effects linear model for the first 3 time points and then did post-hoc paired t-tests, including the final follow-up time point. So we plotted them with rain cloud plots, which are scatter plots, box plots, and distributions over the 4 time points, so across the treatment and at follow-up. The NIH Toolbox measures corrected for age and sex and is reported as a Z-score with higher values indicating better neurocognitive performance. And interestingly, we see an improvement across a number of different neurocognitive tasks, mostly based in the fluid domain. Interestingly, if we zoom in to compare with changes in mood, so with the Hamilton, following a single infusion at TP2, you see improvements in depressive symptoms. At TP3, even more improvements. And at this 5-week follow-up, it's still better from where we started, but they are starting to remit back to baseline. Interestingly, for these neurocognitive improvements, we see the improvement, but we don't really see that remission, which is really interesting. So we're very excited about these findings because we think they really support the existing literature regarding improvements in neurocognitive performance. So to look at associations between depressive and cognitive symptoms, first we did some correlations, still focusing specifically on the sample that has data for 24 hours following the 4th infusion, because that is our largest, most high-powered sample. We looked at correlations between change in neurocognitive performance with change in depressive symptoms, as well as pre-treatment neurocognitive performance with change in depressive symptoms. The results were relatively modest. The only moderately significant results were this correlation between change in flanker inhibition, and which is an attention and inhibition assessment with changes in mood, and then better pre-treatment baseline picture sequence, which is a measure of episodic memory, was modestly correlated with greater improvements in depression. So we were interested in testing out that mediation model that I mentioned the other papers have tested, essentially where you're trying to see if you still see significant changes in neurocognitive performance when covariating for changes in mood. So in our data, we found that there was no mediation and neurocognitive scores changed independently of change in mood, which suggests the possibility that ketamine targets neurocognitive and mood domains separately. So this supports the kind of RDoC hypothesis that the pathophysiology of depression involves multiple partially independent functional systems. So moving forward, we'd like to work on further disentangling how ketamine targets neurocognitive and depressive symptoms. For example, using the functional neuroimaging that we have, it gives us an opportunity to try and distinguish if changes in neurocognitive performance are associated with changes in brain circuitry that are distinct from those associated with changes in mood. It's perhaps also possible that changes in emotionally balanced cognition, also known as hot cognition, such as reward learning and social perception, may be more closely related to brain systems involved in antidepressant response. So we'd like to explore the different types of neurocognitive assessments. Notably, our patients in this study only received 4 ketamine infusions total, and one more serious concern is repeated ketamine treatments may resemble the adverse neurocognitive outcomes that we see in ketamine abuse studies with that continued exposure, even if it's at a low dose. So further research is necessary to investigate how cumulative subanesthetic ketamine exposure may impact neurocognitive performance in the long term. And again, this was a naturalistic design, so testing this with a placebo is important, but it's worth noting that the patients who received ketamine treatment were not primed to expect changes in cognitive function. So just again, a summary, I guess we already covered the first one, but for this paper, we found significant improvements in neurocognitive performance throughout serial ketamine treatment and at a 5-week follow-up that were statistically independent from changes in mood. And so I'd like to acknowledge the funding that made this research possible, the co-PIs of the U01, Katherine, Narr, Randall, Espinoza, Brandon, again, the first author of the diffusion paper, and Noor Al-Sharif, who's a postdoc in Katherine's lab, as well as the co-authors. And I'll take even more questions.
That's lovely. Thank you very much indeed. So if you can either raise a hand or just sing out. Tiago's got in first. Go ahead, Tiago.
Hi. You said about the emotional cognition that you did study. That I can tell you that in my clinical practice, I had a psychologist doing this research on Johns Hopkins scale for cognitive emotions and before ketamine treatment and after remission on ketamine. And she hadn't published that yet. She just finished her degree on it. I can't relate Brazilian to American degrees very well, but the point is, I can tell you that the depression scores, they get better. The inner tension get better, but social skills, they didn't improve after ketamine and after depression remission. So if you want to know more about her paper, we can talk later.
Yeah, that would be great.
I will use the chat for my email, so we can exchange some emails and say about it. But what I can tell you by now is that social skills, they don't get better after ketamine treatment or after depressive symptoms resolution, and people usually needs to have some practice on it. Like there's some psychological ways to improve social skills, and that's really interesting. I write down my email on chat, so you can email me later, and I put you two in touch.
Yeah, that would be great. Thank you so much.
Some Janssen data, wasn't there, from the S-ketamine studies, where I think mostly people's cognition improved, didn't it always the same? But in the over 65s, there was one test that they seemed to do worse on. I'm afraid I can't remember the details of it, but perhaps do you remember what that is, or maybe Wayne would know?
Yeah, I don't remember which one that was. I remember I was having a conversation with someone from Janssen at ECMP last year, and they were mentioning how hard it is to do these like very long-term neurocognitive testing, because at a certain point they just learned the test. But yeah, if anyone knows that specific test with the older group.
I didn't, you showed us the fluid and crystallized data. If you went through any of the individual tests, to sort of more granular level, were there any that where the patients seem to get worse?
So not in the overall trends. We did have 2 patients who did significantly worse mood-wise. So they got worse in terms of the Hamilton, but they seem to not stand out in terms of changes in neurocognitive performance. So overall trends, not necessarily.
And Artemis, can you remind us, I think you had a first slide, sorry, I didn't catch that, when you had this testing done at 4 different time points, right? And then you looked at the data that was 24 hours after the fourth infusion of ketamine. So if, for example, the 24 hours after the 4th infusion, would that be TP4?
So that would be TP3. And
TP4
is the 5-week follow-up.
5 weeks, okay. Right.
If the mood relapses, as you were suggesting it, by the 5 weeks in some patients, and it didn't seem like there was very much mood relapse. Actually, they seemed to be surprisingly well sustained. But the cognitive function is maintained. How can that? I mean, if presumably it's at a sort of rather basic biological level, the ketamine's doing the same thing, you know, in the neurons that subserve mood and cognition. How could that dissociation work?
Yeah, so it's interesting because, right, ketamine is a very dirty drug. So the number of different things that it's targeting, right, is vast. You know, I have nothing to confirm this, right, but we know that ketamine has some anti-inflammatory properties. Since inflammation has been shown to be correlated repeatedly with dementia and cognitive impairment, it's possible that, like, because it's treating inflammation, we're seeing these improvements in cognition that isn't quite as influential to the mood. But that's exactly the question that we're trying to figure out. So what we're really excited about with this data is, in addition to brain imaging, we collected blood to look at peripheral gene expression. So that's actually, I have a fellowship to analyze that data now. And so that's what we're working on, trying to parse out what are the different biological mechanisms that we're seeing occurring, even if it's in the periphery, that might be correlated with one but not the other.
Did you collect ketamine levels as well?
Oh, in terms of like what's left 24 hours later?
I meant, I was thinking more of the peak level that you achieved.
I'm sure we have that data. I myself haven't looked into it, but I would assume we have BMI and we have weight. And so if that wasn't specifically calculated, I'm sure that's somewhere in the data. Do you think that would have that? I guess I'm curious to hear what your thought process is for that question.
Well, obviously you're giving a fixed dose per kilogram, but you'll get a variable ketamine level, and presumably also you'll get a variable level of dissociation in these patients. And you know, I mean, it's just be very interesting to explore both of those two things, the dissociation and the ketamine level, with these biological markers.
Yeah, definitely. That's a really good point.
I mean, do you think at any level, this question I always ask speakers, so I'm sorry about that, but is it, you know, for the jobbing clinician, what do you think this what are the implications?
Yeah, so I think one of the reasons why we pursued this was, again, at that ECMP conference, there was a pretty heated conversation about like the safety of ketamine and whether or not to give ketamine to patients, given that we know that there is potentially this cognitive impairment concern. And it seems like the consensus, given what we're finding and what other people are finding, at least for the more severe cases, with the current dose of ketamine that we give for one round of treatments, that it is safe and it is okay to give them ketamine. And obviously with these like larger pharmaceutical studies that are showing that it's stable as well, just trying to figure out what the risk rewards are. And it seems right now that this is one of the benefits of ketamine. Meanwhile, right, like the alternative, like electroconvulsive therapy may carry alternative risks in terms of.
You've got data on that, haven't you?
Yeah, we do. So we haven't dug into that yet, but that's next.
So you'll have you'll have a small comparison of ketamine versus ECT, but presumably patients weren't random. Were they random? No, they weren't given.
No, it was essentially like
assignment
different.
wasn't random, was it? No.
Yeah.
Okay. So, but that will contribute to the interest in the comparison there.
Mm-hmm.
So we've got a couple of questions in the chat. Were other substances controlled and confirmed? Cannabis, alcohol, benzos.
Oh yeah, so participants were excluded for substance abuse in the last 3 months. Now, in terms of cannabis and alcohol specifically, I can't remember off the top of my head what the exclusion criteria was, but I'd have to go back and check for that. But comorbid substance abuse was an exclusion criteria.
And presumably you looked in the urine for these substances.
I believe so.
Yeah. Okay.
And Artemis, I think you showed then the correlation with the clinical improvement, right? It was like the cognitive data and the clinical improvement. And I was also wondering if you have any plan to do the same with your, if this was the same sample as I assume it was, with your white matter data.
Yeah, so that's definitely something, again, this was more of a introduction to these cognitive scores that we had sitting in our lab that nobody had really touched yet. So this was like a prequel of trying to figure out what's the next brain imaging assessment. I would start with functional just because we know the effects are a bit stronger there. In terms of what we saw structurally, again, it's very subtle and it potentially very transient. So yeah, functional first and then working towards the structural findings as well.
I think we got another question in the chat.
Were there any other significant comorbidities like pain?
Not that I'm aware of. I would have to go back and look at the inclusion-exclusion criteria, but I can't remember if we excluded like chronic pain as a sorry, when you comorbidity as in what the patient had instead of what they're presenting with following.
Yeah, it was my question. Hello, Artemis. I was just wondering if some of the patients had chronic pain or neuropathic pain, or because this cognitive impact could be on chronic pain as well, and that could be interesting on the chronic pain side. So maybe could be interesting afterwards if you could just maybe double check, because that could be very interesting, because we've got quite a number of studies of pain patients rather than depression, but we're showing that there are quite a number of intersections between both. So could be interesting to see if they improve on pain as well. Okay.
That's a great point. We can definitely look into that.
Thank you.
That's a very exciting question. Thank you.
Okay. Any other questions?
Oh, and sorry, I see in the chat about benzodiazepines. So they were asked if they were on benzodiazepines to refrain from using benzodiazepines for the duration of the study.
Well, this was beautifully clear. Thank you. Thank you very much indeed. That was lovely.